Good day, everybody. I'm Anna Plotkin, Director of the Continuing Professional Development at the Department of Laboratory Medicine and Pathobiology at the University of Toronto. Welcome to the breast community of interest. Today's sessions will be moderated by Dr. Jessie Wu from St. Michael's Hospital / Unity Health. And we have exceptional lineup of cases, as well as our keynote speaker, Dr. Anna-Marie Mulligan from University Health Network. Jessie?
Hi, good afternoon, everyone. Welcome to the Spring 2023 Breast Community of Interest meeting. Thank you so much for joining us. My name is Jessie Wu. I'm a breast pathologist at St. Michael's Hospital in Toronto, and I'm also the host for this meeting. We have a fantastic program today, and this is reflected in the number of participants that have signed up today. We're going to kick off the meeting with a lecture from Dr. Anna-Marie Mulligan, followed by a question and answer session, and then we'll have a presentation of interesting cases afterwards. Okay, so to start off, I'd like to ask, how many of you wish you have a breast pathologist, a breast expert next door where you can just pop around and show cases where you have doubts about your diagnosis? And do you ever wonder, if you're the only one who can decide if something should be called ADH or DCIS? Well, Dr. Anna-Marie Mulligan is here today to talk to us about common problems encountered in breast consultation service. Dr. Mulligan is one of those speakers who really needs no introduction, in addition to being one of the moderators for our breast community of interest meeting. She's a staff pathologist at University Health Network, with a wide range of research interests in breast pathology. She's pretty much touched on everything. Most recently, she formulated the recommendations from the Canadian Association of Pathologists Task Force on the Ki7 testing in breast cancer. She has published over 200 articles with over 15,000 citations. So we're very, very honored to have her here with us today. So please join me in welcoming Dr. Anna-Marie Mulligan.
Thank you, Jessie, for that very generous introduction. I don't know if I'm quite at that number, but I'll take it if you're offering it. So let me see. So hopefully you should be able to see my full screen. Let me minimize this. Okay. So thank you, Jessie, and to Anna for inviting me to present today. So let's see. So for this presentation, I've been asked to share my experience of the UHN breast pathology consult practice. Personal consults are one of the more challenging aspects of our work. They represent cases that have been seen by a pathologist, often a very experienced pathologist, and yet present a diagnostic difficulty. In this way, personal consults do select for those particularly challenging cases. And even after a decade and a half working as a breast pathologist, I still maintain that easy consults are few and far between. So consults come in a variety of types. For example, they may represent rare entities that the referring pathologist hasn't diagnosed previously, but are classic for that entity in terms of their morphologic and immunohistochemical profile. And such an example is seen here in this core, which demonstrates these multiple nests of cells with the suggestion of a papillary architecture and the presence of eosinophilic secretory material. The nests are lined by this double layer of columnar cells with apical location of the nuclei, as well as scattered somomatous calcification. So these are features in keeping with tall cell carcinoma with reversed polarity. And I think we all enjoy these types of consults. Not only do they afford us the opportunity to see and diagnose a rare entity, which we still get somewhat excited about, but we also have the satisfaction of being able to render a definitive diagnosis, which unfortunately is not always the case with consoles. These types of consoles are, however, rare. The next type of consult isn't so rare. These are the lesions in which the entity is clear. However, the classification or grading of the entity is problematic. And a typical example of such a consult will be Fibroepithelial tumor, where the grading is not always as straightforward as the textbooks would suggest it should be. And I'll talk more on this later. Then there's the category of borderline lesions. Is this lesion best classified as ADH or DCIS? Is it non-atypical or minimally atypical? And these are the common problems seen not only in our consult practice, but in the daily practice of any breast pathology service. So to inform the content of this presentation, I took a snapshot look at personal consults that I've reported recently, looking at a consecutive series of 100 cases. And because of workflow issues, any consults that come in are directed to the pathologist who is on the clinical service schedule on that day, regardless of whether it is addressed to a specific individual. So any potential biases in the type of cases I've seen over the period evaluated should be minimized. So for this particular period, the cases comprised 39 core biopsies and 61 excision specimens. I also took a look at the accompanying documentation to determine reasons the consultation was being sought. There was quite a bit of variation in what was received. Many included detailed letters with a very specific query that pertained to one aspect of the case only. And these cases do allow us to focus on that particular aspect when evaluating the slides and when writing a report, and likely provide the most educational benefit to the referring pathologists. In other cases, the referring pathologist may have detailed the scenario that led to the case being sent, such as differences of opinion within their department. And in about 10% of cases, an accompanying letter was not received. However, in these situations, the pathologist typically included in the report a comment that the case was being sent to UHN. So this occurs usually in the core biopsy setting and is likely for QA purposes as well as diagnostic confirmation. In terms of other included, actually, let's turn this on. In terms of other included documentation and information, imaging findings were submitted in some cases, and this is very much appreciated and in many cases necessary for reporting the case, and this is particularly so in the setting of a core biopsy. We consistently teach our residents and our fellows that before reporting any core biopsy, the radiologic target must be known to avoid missing a discordant finding. Similarly, in cases querying ADH versus DCIS in an excision specimen, being able to see a copy of the block diagram and knowing the imaging and prior core biopsy findings does facilitate interpretation of what's on the slides. So here we see a breakdown of those 100 cases. What's clear is that the majority of cases pertain to one of three types of entities, and I'll address these in greater detail shortly. And the remaining cases comprise a small number each of adenomyoepithelioma, sclerosing lesions, margin queries, tumor typing queries, confirmation of invasion and suboptimal specimens, and queries regarding the presence or absence of microinvasion. There were 9 spindle cell lesions, and then a variety of queries made up the last 12 cases. So the 3 dominant consult themes include fibroepithelial lesions, papillary lesions, and intraductal proliferations, which was the largest category, representing 24% of consultations for this period. So intraductal proliferations accounted for 24% of all cases, and these could be further broken down as follows. Is it atypical or not atypical? Is it ADH or DCIS? And a couple about lobular and neoplasia, but not a lot overall. So the biggest single challenge seen in this series is in the diagnosis of atypical ductal hyperplasia. So the term ADH was originally coined For those lesions where either the cytologic or architectural features of DCIS are seen, but both are not fully developed, that is, there are some, but not all of the qualitative histologic features of DCIS, which are defined as firstly, the presence of a uniform population of cells. Uniform as these lesions represent a clonal proliferation of luminal type cells. And secondly, this clonal proliferation forms these smooth geometric spaces or micropapillary formations with even cellular placement. So if these cytologic or architectural features only partially involve the duct, with the remainder being occupied by cells of usual hyperplasia, then a diagnosis of ADH is rendered. But we also have to consider quantitative criteria in the diagnosis of low-grade DCIS, and this came into play back in 1985 in the study by Page and colleagues, where in order to foster inter-observer agreement, they adopted an arbitrary rule for DCIS that two spaces had to be completely involved by a uniform population of cells, demonstrating a defined architectural pattern of DCIS. And subsequently, Tavasoli and Norris emphasized microscopic extent, and they chose to classify foci measuring less than 2 millimeters as ADH, regardless of the number of involved ducts. As such, quantitative criteria are arbitrary and lack biologic validation. So the diagnostic challenges are seen at both ends of the spectrum in distinguishing ADH from hyperplasia of usual type or UDH, and at the other end, distinguishing ADH from low-grade DCIS. So UDH, it represents a mixed non-clonal proliferation of luminal cells, basal cells, intermediate cells, and in contrast to ADH and low-grade DCIS, where uniformity is the rule, the cells of ADH, they vary in their shape, their size. Similarly, they lack that even placement, with cells showing overlapping, uneven nuclear spacing, and they demonstrate the swirling or streaming pattern. So all this leads to a rather disorganized appearance. And if spaces are present, they're typically irregular and slit-like and located peripherally. And in difficult cases, we can exploit the clonal or non-clonal nature of the intraductal proliferation with the use of immunohistochemistry. So a mosaic pattern of high molecular weight cytokeratin will be seen in the mixed population of UDH, whereas the clonal proliferation of luminal cells, characteristic of ADH, will be negative. But even with these established morphologic criteria and descriptions that separate ADH from UDH, and with the immunohistochemical aids to make the diagnosis, we can still struggle. And that's especially seen in the following situation. So if the involvement of the duct by the clonal proliferation is very limited, it may be challenging to identify it as such. And in these cases, levels are extremely important. Metaplastic changes, often seen in usual hyperplasia, they can lead to an appearance of cellular monotony, such as the case with apocrine clear cell or columnar cell change. A monotony is, of course, a characteristic of atypical ductal hyperplasia. So recognizing that the monotonous appearance is a result of the metaplastic process should help to avoid misinterpretation in this setting. And finally, certain architectural patterns are particularly challenging, such as papillary and micropapillary patterns. So here we see intraductal micropapillary proliferations. On the left, you can see these broad-based papillae with tapering tips and a somewhat pygnotic appearance to these pinched tips. The cells appear hyperchromatic at the tips in contrast to the normochromatic appearance of the cells lining the space. There's crowding and overlapping, leading to an overall disorganized appearance. So these are the features of micropapillary hyperplasia. And in the atypical example on the right, the papillae, they're narrow-based and have these broad bulbous tips, and the cells are similar to those lining the duct. So the appearance is uniform through it. So separating ADH from DCIS is probably even more of a challenge. And although we do have established criteria to delineate ADH from DCIS, in reality, such sharp distinction is rare, and usually we encounter a spectrum of changes leading to uncertainty in where to draw the line. And multiple inter-observer studies have demonstrated that pathologists do not agree consistently here. And in this study by Elmore and colleagues, which you'll likely be familiar with, participants achieved an overall concordance rate of just 48% compared with the consensus-derived reference diagnosis in atypia cases. Moreover, among the three reference pathologists, their independent pre-consensus diagnosis agreed with the final consensus-derived reference diagnosis in just 80% of cases. So this is a major source of diagnostic variability in breast pathology, even among experts. So why is this? Well, there are many scenarios where we struggle to apply the 2 millimeter two-space rule. These include situations where there are multiple ducts involved, but the involvement isn't complete. So how many partially involved ducts do we need to see to warrant a diagnosis of DCIS? And indeed, is it appropriate to consider a diagnosis of DCIS if involvement is incomplete? And it's probable that we all approach these cases differently. Subjectively, we may get the impression that there's just so much of it, it's best regarded as DCIS, but this approach does lack objectivity and therefore reproducibility. Applying the 2-duct 2 millimeter rule isn't possible in some situations. For example, when atypia involves a complex sclerosing lesion or a papillary lesion, and generally a greater extent of atypia is acceptable in these settings, but we will vary in how much atypia we are willing to see before a diagnosis of DCIS is indeed rendered. And multiple foci are present. Should this be considered multifocal ADH or DCIS? And in these situations, I think it's important to consider the appearance of the foci. Are they morphologically different? Then if so, you're likely dealing with multifocal ADH. If, however, it is extensive and the foci are morphologically similar, then I think one does need to consider that the lesion is an unusual pattern of DCIS. And is it DCIS at the margins when the spaces close to the margins show less well-developed features? Well, if the main lesion is indeed DCIS and the foci close to the margins appear in continuity with the dominant process, then the most likely answer to that is that these should be considered as part of the DCIS process. So in both these scenarios, and in fact, probably in all of these instances, mapping the sections is crucial, and this is regardless of what type of template you choose to use. Mapping allows you to determine how involved sections relate to one another, which will help in ascertaining extent as well as determining margin status. Furthermore, in specimens that haven't been submitted in total, it will help guide where extra blocks should be taken if required. So some final words on ADH versus DCIS on excision specimens. Don't underestimate the value of deeper levels in these borderline cases. Also consider extra blocks in cases that haven't been embedded in total, and always consider the core biopsy as well as the imaging findings when putting the final report together. And in the core biopsy setting, be conservative. In borderline cases, it is better to err on the side of calling the lesser diagnosis, and use of the phrase at least ADH, or the term that we typically use here, atypical ductal epithelial proliferation. This is appropriate in these particular settings, and definitive classification then can be deferred to the excision specimen. So the next major category is that of fibroepithelial lesions, which accounted for 23% of cases in this series. And there were two main themes to the questions. Firstly, does the lesion represent a fibroadenoma or a benign Florey's tumor? And how should this Florey's tumor be graded? Both main questions do arise from the fact that morphologic features of fibroepithelial lesions represent a continuum, and making a clear-cut distinction then between the constituent entities can prove to be problematic. So fibroadenoma versus benign phylloides tumor. So when the diagnostic features of phylloides in the form of cellular stromal fronds are present, then the diagnosis, it's straightforward. However, there are many instances when the histologic features will overlap between these two entities. And this is most commonly the case when you have a fibroepithelial lesion with cellular stroma. However, the leafy architecture is absent or it's not well developed. And both of these entities do share a number of morphologic similarities, and the features that aid in their distinction can be subtle and poorly reproducible. So features to look for include the uniformity of cellularity, which is typically the case in a cellular fibroadenoma. The lesion as such will appear homogeneous throughout, regardless of where you look. In benign phylloides tumor, however, heterogeneity is often present, and this may be in the form of areas which are paucicellular or sclerosed, admixed with more cellular zones, or it may be seen as periductal accentuation, where the cellularity adjacent to the epithelial elements is higher than away from the ducts. It's also important to perform multiple formal mitotic counts. While we can see mitosis in cellular fibroadenoma, they tend to be more numerous in benign phylloides tumor and may be present throughout the lesion. So in borderline cases, I'll typically do mitotic counts in every block, focusing on the more cellular areas. Another complicating factor is that a leaf-like architecture does not always represent phylloides tumor. Leafy structures can be seen in the presence of a prominent intracanalicular pattern, and typically these are not well formed and they're not associated with stromal cellularity. The leaf will fit the space it is in, like pieces of a jigsaw puzzle. Whereas in phylloides, the stromal fronds, they continue to grow and expand out of synchrony with the space wherein they lie, and they don't conform to that space. And finally, fibroadenoma-like areas with associated hypocellularity can be found in phylloides, and as such, it is important to sample these lesions well, and additional blocks may be warranted in borderline cases. So inter-observer variability in making this diagnosis has been assessed. This particular study included 10 subspecialized breast pathologists, each rendering a diagnosis on 21 referred in cases. In only 2 cases was there 100% agreement, and in 9 cases, 9 out of the 21, the diagnosis varied from fibroadenoma to borderline phylloides tumor, with more than one pathologist assigning the lesion to the borderline category in 4 of these cases. Not surprisingly then, the pathologists did better if the diagnosis of fibroadenoma and benign phylloides were combined, with 100% agreement being reached in over 50% of cases, and 90% agreement in 79%. So in terms of grading phylloides, 3 categories are recognized by the WHO: benign, borderline, and malignant, and a number of parameters characterize each of these categories seen here. So benign phylloides are typically well defined, whereas malignant will show permeative edge. Similarly, the cellularity, stromal atypia, mitotic counts, they increase with increasing grade. However, any one lesion can show features from 2 or even 3 categories, and while it is recommended that we consider the features collectively rather than emphasizing one individual feature, it is inevitable that such lesions will be prone to inter-observer variability, with little guidance being available on how we should handle these cases. A further complicating factor is how malignant phylloides are defined in the latest iteration of the WHO book, which states that a diagnosis of malignant phylloides is made when all 5 parameters fall into the malignant category, or if a malignant heterologous component other than well-differentiated liposarc is present. So while the goal of this recommendation is to prevent overdiagnosis of malignant phylloides, there is data to suggest that Malignant behavior can be seen in examples of phyllodes that do not fill this or all criteria. And here's an example of a challenging diagnostic case. So low power reveals this well circumscribed fibroepithelial lesion with non-uniform stromal cellularity. Some areas, the appearance is indistinguishable from a fibroadenoma with paucicellular areas. And then we have these scattered more cellular zones. There were several 4X fields consisting of stroma only, fulfilling the criteria for stromal overgrowth. And the cells demonstrate at least moderate cytologic atypia with brisk mitotic activity, which amounted to more than 30 mitoses per 10 high power fields. So this is a lesion that has most, but not all of the features of malignancy, given that it lacks an infiltrative border and by WHO criteria does not fulfill the criteria for malignancy. Yet inevitably a case such as this may be classified as borderline or as malignant by different pathologists. So the final major group of lesions is that of papillary lesions, which accounted for 14% of consults in this series. I did think it might be bigger. So papillary queries comprised 6 cores and 8 resections. Core biopsy queries consisted predominantly of classification queries, whereas in the excision specimens, the questions were how to classify this papillary lesion with atypia, how to classify this papillary carcinoma, and is there invasion in this papillary carcinoma? Papillary lesions on core can be particularly challenging. They are prone to fragmentation. Their architecture can be difficult to appreciate in limited and disrupted samples. The edge of the lesion might not be included to permit assessment. And diagnosing conventional patterns of invasion in the setting of an encapsulated papillary carcinoma or a solid papillary carcinoma can be perilous in a biopsy setting. However, depending on how a papillary lesion is classified in a core biopsy, the management may indeed be very different. So for papillomas involved by ADH or DCIS, and for papillary DCIS, the treatment should be the same. Complete excision. This will facilitate appropriate management of the lesion, as well as permitting a final classification to be rendered when the entire lesion is available for assessment. The management, which follows the diagnosis of solid papillary carcinoma in situ and encapsulated papillary carcinoma on core, will also be excision. However, depending on the imaging and clinical findings, a decision to include a sentinel node may be made. Similarly, if a diagnosis or suspicion for microinvasion or invasive carcinoma is made in any of these settings, then it's likely that a sentinel lymph node biopsy will also be pursued. On the other hand, a diagnosis of papilloma without atypia may prompt follow-up rather than excision. So at this point, it's crucial to make that distinction in the setting of a core biopsy. And making this distinction between an atypical and non-atypical papillary lesion again involves applying the same rules as outside the papillary setting that we just discussed. So the key is to look at the proliferating cells between the fibrovascular cores. So in this example, you can see quite a florid epithelial proliferation between the cores. But you see also the features of usual hyperplasia, the cellular streaming seen on low power and on higher power, cellular heterogeneity, overlapping, slit-like spaces. They're all appreciated and are characteristic of epithelial hyperplasia of usual type. In contrast, in this very fragmented specimen, low power reveals a homogeneous appearance. Confirmed on higher power, where this uniform population of cells are seen between the fibrovascular cores. These demonstrate even cell placement and some geometric spaces, and it's clear that the epithelial population is atypical. It's challenging, I think, to go beyond that in this particular case, and the differential I would include would be papillary DCIS, DCIS extensively involving a papilloma, and encapsulated papillary carcinoma. In this final example, we see again a uniform population of cells with cribriform structures, but also a peripheral capsule is included in one of the cores, and myoepithelial cells were absent from the periphery of this lesion, and these findings do point to a diagnosis of EPC, encapsulated papillary carcinoma. So how can we use immunohistochemistry to help us? So myoepithelial cell markers in the setting of papilloma versus papilloma with ADH or DCIS, they're of limited use. So myoepithelial cells will be preserved at the periphery of the duct, as well as lining the fibrovascular cores in both of these lesions, although you may see some reduction in staining in the region of atypia in the case of the latter. In papilloma versus papillary DCIS, they are useful as they'll be preserved at the periphery in both lesions, but are typically lost or markedly reduced from the fibrovascular cores in DCIS. In EPC, they're typically absent from the periphery of the lesion and from the fibrovascular cores. And in solid papillary carcinoma, they are absent from the fibrovascular cores, and they may or may not be preserved at the periphery of the ducts. And I apologize, I don't have an immuno to back that up. So the markers that I find most useful to confirm or exclude an atypical proliferation is the combination of CK5 and ER. And we looked at this a number of years back in a study performed specifically in the setting of papillary lesions on core biopsy. We anticipated that the low-grade neoplastic proliferations would include a diffuse ER staining and an absence of staining for CK5, and that usual hyperplasia would show variable ER staining combined with the mosaic pattern of staining for CK5. And for the most part, this is what we saw. And you're all familiar with the combination of these immunos in these atypical settings. So there are two main scenarios where the ER CK5 staining pattern doesn't hold. The first is in the case of apocrine proliferations, where both ER and CK5 low or absent staining will be seen. And the second is in high-grade proliferations, where ER may be low or absent and CK5 might be absent, but it may also show block rather than mosaic positivities. These are the two major exclusion areas when assessing these. Furthermore, these stains are not useful in cases where the fibrovascular cores are lined by a single layer of columnar cells, which may be expected to show diffuse ER staining and absent CK5 staining. So my point here is that it is vital to consider the H&E appearance when interpreting these stains to avoid misinterpretation of these staining patterns. Okay. Nearly done. On excision specimens, the questions, they also involved classification of papillary lesions, as well as introducing that challenging question of when to diagnose invasion in the setting of EPC or SPC. So identifying frank invasion is typically straightforward. This component will look distinct from the encapsulated papillary component, typically being of ductal no special type in appearance. And it'll show invasive disease extending beyond the zone of reactive stroma with invasion into fat or around normal breast structures. So here we can see, let me go back to my pointer. Okay, so here we see another example with a small focus of invasion present beyond the capsule and extending into fat. The recognition, however, of lesser degrees of invasion or minimal invasion is more challenging. And in the absence of a recognizable conventional pattern of invasive carcinoma, extension of malignant papillary clusters beyond the capsule is also used as evidence of invasive carcinoma by some, not seen in this particular image, by the way. And this can be challenging because often the capsule isn't well formed, or it merges with dense fibrous breast stroma, and its boundary really is poorly defined. So making the diagnosis of invasion in these settings, one does have to be wary of pseudo-invasion and other features that can disrupt the edge of the lesion. So many EPCs are bounded by zones of fibrosis, hemorrhage, and inflammation. This can lead to sclerosis with disruption of the regular rounded contour and entrapment of malignant epithelium. So these pseudo-invasive nests will typically run in parallel to the capsule, and a clear desmoplastic response will be lacking. Similarly, epithelial displacement following a needling procedure can result in epithelial fragments being displaced remote from the tumor within the core biopsy tract. We know that papillary lesions are particularly prone to this phenomenon. So clusters of epithelial cells that are isolated to the core biopsy tract should be interpreted as representing displacement rather than true invasion. So in summary, a few themes dominate the consult service at UHN. These include common everyday issues where, despite having defined criteria, they are difficult to apply consistently. But they also include less common entities where various boundaries and definitions are somewhat obscure, making it challenging to foster reproducibility between pathologists and ourselves. And these are areas that do require greater study as well as clearer guidance for the pathologists. So with that, I will stop, and I would welcome any questions or comments.
Thank you, Dr. Mulligan, for a fantastic talk and a very pragmatic approach. So I think we have a question in the chat already, and it's about whether you do both CK5 and ER to distinguish between ADH and VDH, or is CK5 in itself sufficient?
So I think it depends on the situation. In most cases, I think we all have a fairly good idea if we're dealing with an atypical or non-atypical proliferation, and we're just sort of adding the CK5 just to be sure that we're right, especially if it's an important question pertaining to margins or on a core where excision or non-excision would be the outcome. So, I'll alter what I order depending on, I guess, my degree of concern, but also the setting. So in the papilloma papillary setting, I'll typically do both, I do have to say. Just because they tend to be harder just to put together given the disruption. The architecture is more difficult to appreciate. You get a lot of artifact that can hinder your interpretation. So the two together always, they can add, they're additive. So is the answer you should always do ER as well as CK5? I think no. It really does depend on your level of suspicion and how many aids you'd like really to go along with confirming your diagnosis. With, probably for my personal exception would be papillary lesions. I tend to like to do both, but we're cognizant of how much work the lab has to do with immuno and the cost. So I don't always do both together, I guess. Long-winded answer to the answer is no.
So there's a follow-up question. So if the CK5 ER does not fit your impression on H&E, do you come back to your diagnosis on the H&E, or how much does the immuno part actually sway you?
Right. So thanks, Pratibha. That's a good question. So in general, I try not to let immuno sway me too much. If on H&E I'm confident of my impression. You might ask, well, why do I do the immuno if I'm confident? I don't know. There's a lot of self-doubt here, obviously, that I like to check. So if it's one of those, I can go either way. And, I'm looking at it with a fellow and they think one thing and I think the other thing. And, it's one of these difficult to interpret. Then certainly I will consider the immunos in kind of, making me just stop and think, maybe I was too rash and, having my preformed idea that this is what we're dealing with. So it doesn't often come back as a surprise finding. When it does, I will go back and look at the H&E and try and explain it. I need to reconcile where that discrepancy is really. And there's usually a good reason for that. It may be that I didn't look carefully enough in the first place. But it would be unusual, really, if you're confident that it's atypical or not atypical, that the immuno goes against it. There may be something odd going on. And when it does go against your initial impression, it's probably one of those difficult to interpret lesions anyway. And in that case, I'd probably put it all together before reaching my final conclusion.
Right, and there's another question from Dr. Polycarp. So it's about, do you use androgen receptor to evaluate apocrine differentiation in equivocal cases of apocrine differentiation / ER negative cases?
I don't, Polycarp. Let me see, is that the honest answer? Do I use AR? So to evaluate, to see if I want to call it apocrine, I guess, rather than just ductal without an apocrine morphology. I don't think I've done that. I may just be forgetting, but I don't think I have done that. I'd base it really on the morphologic appearance. If it had apocrine, if the cells had apocrine differentiation that I was confident with. In terms of androgen receptor, I really don't use it all that much at all. Occasionally we are asked to do it in cases of invasive carcinoma if we've commented that it had apocrine features and the patient might be eligible for, some particular therapy. But I don't know, in the intraductal setting, I don't think I've used androgen receptor.
Anna Marie, I have a question. First of all, this was an excellent talk. I want to go back to the second portion of the talk where you talked about fibroepithelial lesions, and you presented this super challenging case that hit 4 of the 5 criteria for malignancy. And you said, well, this is a very difficult case. My question to you, how did you report it?
I was hoping nobody would ask me that. So I have to declare that that case I took from a talk I have on fibroepithelial lesions that I used to give at an ASCP course that we did for a number of years. And it was pre the latest edition of WHO. And I used to show that case as a case that even though it didn't have all the features of malignancy, I thought it was malignant. That was my diagnosis. So, that's why I think I struggle with this need or this recommendation that you have all features, because we all get these cases that just don't sit comfortably with us for leaving in a borderline category. And I know I've had some phylloides recently on consult that didn't have all the features, but I put in my concern that, the features are concerning for malignancy. Even though the data isn't, we don't have a lot of data on it, but malignancy metastatic behavior has been reported in some instances. So I'll put that in as sort of my note of concern. And I think we all struggle with that because they put it out there, but yet when you hear the authors of that chapter speak, they'll admit that, oh, well, they don't always need all 5 parameters. So it kind of leaves the rest of us in a difficult situation. So that particular case back then, I used as an example of malignant fibroepithelial or phylloides tumor, even though it didn't have the permeative borders. So I don't know, would you agree? What would you call it? Or anybody?
I actually sometimes do that. I call even like borderline with concerning features. And I would just say that current recommendations are to use all 5 criteria, but that in this case, I do have significant concerns that this is going to behave more like malignant, given the spectrum of borderline lesions. But I share your pain. I feel it. These are the most painful.
Yes.
Yeah.
Most of the consults can be, obviously a lot of them fall into that category or the borderline category. And, we all struggle. And I think that's why they're a challenge, because you're always left with that little bit of wonder, a doubt, or, am I right here? Am I assigning this in the best way possible? So they're a challenge. That's why it's easier when you have that nice, clear-cut, obvious tumor that has molecular confirmation to go along with it or whatever. It's these ones that we're all challenged, we're all struggling with.
I can only say there is a presentation at the current USCAP that is still available on demand by Gulisa Turashvili on exactly that topic. So if you apply all 5 criteria, you miss significant number of the malignant phylloides.
Absolutely, yeah. Which I look forward to seeing that paper published. It'll help us all. And even Sharon, your paper from Sunnybrook with Elsbieta, I mean, you were identifying cases that didn't have all the features that behave malignantly. So they're difficult. Yeah. No such thing as an easy consult.
We have one more question in the chat, and maybe then we'll move forward, right? So thank you for your talk. Do you diagnose benign papilloma on a core biopsy because these lesions are heterogeneous and the core may not represent the whole lesion?
Thanks for the question. Yeah, I'll diagnose if I don't see any atypia, I call it papilloma or intraductal papilloma or fragments of a papilloma or whatever it might be. In my comment, I'll say no evidence of atypia in this limited sample, and leave it at that. I mean, there's so many studies we've done on ourselves on, upgrades following a core biopsy diagnosis of a papilloma. And, the better studies will all show that the percentage of upgrade rate, the upgrade rate is low. It's going to be less than 10%, might even be 5% or less, if there is good radiologic pathologic concordance. So our surgeons, they know what it means to have a diagnosis of a papilloma on a core. They know that there is a chance, but a small chance, that there'll be an upgrade following excision. And they have this conversation with the patient. The patient may choose to have it excised, or they may be happy to follow it. There are situations where excision will be required, even if it is, benign or non-atypical on the core. So, I mean, if it's symptomatic, our surgeons will typically take it out. And also, the larger it is, obviously the chances of undersampling will be higher, or if there's RAD-path discordance, and so on. But, many patients are willing to accept that risk, that, knowing that it's low, and are happy to be followed. But patients differ. So it's kind of thing that the surgeon will discuss with the patient, and, it'll be individual based in a lot of cases. I know that we can do that here because we have that constant interaction with our clinical colleagues. So they understand what we're saying when we say something in a report, and it may not always be the case, in other centers. So, you may need to be more explicit if there is something that you're concerned about and you're not, you're unsure if it's atypical or not atypical. So these are the cases that perhaps you might want to talk to your surgeon about excising. But yeah, I'll just call it papilloma if I don't see anything that I'm concerned about as atypical on the core.
All right. Well, thank you so much for this amazing talk. Thank you, Dr. Mulligan. And we'll move on to the presentation component of our meeting. So first presentation, it's from Dr. Sono Varma. Would you like to share your screen?
Sure, I'll just share my screen quickly. Well, good afternoon, everyone, and thank you for letting me present this case. This came along a few weeks ago, actually. So this is a 36-year-old female. She had a palpable lump, and the mass has been present since 2019. That's the time she was pregnant and she felt something, and so it was looked at and biopsied. And we had received the original biopsy as well, and it was called fibrocystic changes, and nothing malignant there. So they left it alone until now. So last year, like end of November 2022, she had another ultrasound done. And at that time, the size had increased to 9 centimeters instead of 5.7 centimeters in 2019. And now the radiologist's comment was that there are hypo and hyperechoic foci, and then there's also an anechoic focus, which may be suggestive of cyst. They gave it a BIRATS-3, and so probably benign, but because it was there for a while and it was growing in size, it was taken out for more definitive diagnosis. From the surgical note of the surgeon, he thought that it was a galactocele because when he was taking it out and he ruptured it, there was all this white material coming out of it. So he was pretty confident that it's benign and it was galactocele. So I'll just show you the radiology here.
Sorry, Sunal. I think that you're not sharing the screen.
Radiology pictures from this person. So there's a large lesion, as you can see. This is the ultrasound picture with some, a lot of, anechoic or hypoechoic areas, and then some hyperechoic, more solid areas. This was actually a video which I tried to upload, but it didn't work very well. So that's probably the theme of the day today for me. So then I'll show you the gross. We got the excision, and you can see it's a big cyst in there. And then in keeping with what I showed you on ultrasound, there are edges that are more solid type of lesions, really solid, and then this large cyst. So here's a close-up of one of the slices here. So you can see, one dominant cyst, but there are multiple, lots of small cysts, maybe filled with some gelatinous material, and then some papillary kind of growth into the cyst, and then these solid components. So now here's a kind of a whole mouth picture for you. So you can see those small cysts, like there are tons of
Yellow,
those.
9 all clear. Code yellow, 9 all clear. Code yellow, all 9 all clear.
So here's that portion of the dominant cyst wall, and then this is the wall where there are multiple cysts with solid components. So now going into a little bit of the microscopy here. So those papillary fronts that you were seeing are indeed, they look like, this could be a papilloma, but not quite. It's papillary in that sense that it's protruding into the lumen. And some of these, they have these kind of large papilloma-like fronts, lots of cysts, some inflammation in the background, and some other lining that you can appreciate here. Now, as you go closer, there are these multiple ductal and glandular structures that you can see, lots of stuff going on, but nothing looks atypical. You go to another area, and here there are ducts that are filled with these macrophages, and this is one of the characteristic findings in this lesion as well. But also look at the stroma. If you saw only a biopsy from this area, you would wonder about the fibroepithelial lesion, maybe a fibroadenoma. So it has those fibroadenomatoid areas as well. Again, this is very low power view to just give an appreciation of what the lesion is like. Those fibroadenomatoid areas, more that fluffy bluish stroma, then some hyalinized stroma, large ducts. So you start wondering what exactly is going on here. Again, more of that fibroadenoma type stuff. So with this constellation of findings and such a large mass in a young woman, there's really only one diagnosis that comes to mind, and that is juvenile papillomatosis. This was first coined by Dr. Rosen in 1980s, and he was very fond of this diagnosis. So during our fellowship, that was the first thing you heard about from him. And if you misdiagnosed, then you were in trouble. So just a little bit more about this entity. It occurs in younger women, 20 to 40 more commonly. If you see a big mass that has all these constellation of findings, like lots of proliferative changes, non-proliferative changes happening all in one mass-like lesion, chances are you're dealing with juvenile fibromatosis. Now, just the diagnosis or the entity on its own is not such a bad diagnosis to have, and the person would be relieved. But in about 15 to 25%, depending on where we read, they may be associated with invasive or in situ carcinoma. So once we saw this, we went back and submitted essentially all of the lesions. So ended up with like 60 slides on this case, and there was nothing in this particular case. So the point is that you have to be diligent and exclude concurrent invasive or in situ carcinoma or atypia of some sort. The other significance of this diagnosis is that in up to a third to up to a half of patients, so 35 to 58% of patients, there will be a family history of breast carcinoma. So if the patient's family, if patient doesn't have a family history, which in this case she didn't, then probably it should trigger screening in the family as well. Now, the connection between, there have been no consistent germline mutations identified in this particular entity. So the connection between family and JP has not been well studied, and probably because of rarity of cases, and we can't really get enough cohort to look at it. But in some Cowden syndrome type patients or some other familial associations, there has been increased incidence of JP. So that's something, maybe a small connection there, but regardless of whether we know it or not, there has been documented association with family in up to half of patients. So this is an important diagnosis from that regards. From her personal risk perspective, it only has been shown to increase mildly, and that may be because of having a family history. So another reason for having increased risk rather than JP itself, but we don't know that for sure. So on that note, there is this paper that came from Tim Delfonso and Reese Fillo's group at Memorial, and they have studied, they did whole exome sequencing on a few of the JP cases, and this is the particular one which I wanted to show you that can have invasive carcinoma associated in a younger person. So you see the whole classic JP type change, and then here you have invasive carcinoma. Typically, these will be ER positive ductal carcinomas, but lobular carcinomas and mucinous carcinomas have also been shown to be sometimes concurrent with JP. So benign JP doesn't have very many genetic alterations, and until maybe 3 years ago, we thought that there wasn't anything that was clonal in these lesions. But it was shown by Tim's group and a few other groups before him that somatic PIK3 kinase hotspot mutations were recurrent in these lesions. In up to 80% of JPs, you can have PIK3 kinase mutations. What they also showed was there were some aging signatures, especially aging signature 2 and 5, that were associated with these lesions, and those were the ones. Again, this is very sort of not causative yet, but may be associated with concurrent DCIS or invasive carcinoma. But at least, we have shown the connection that there's a clonal relatedness, and these DCIS and IDCs that are associated also have the same hotspot PIK3 kinase mutation as the JP next door. So there is some relatedness there, but it's still early work, so it needs to be proven in more cases. So in terms of writing the report, more practical aspects, this was my report, that, there's a constellation of findings, everything is in together, and this is consistent with juvenile papillomatosis. And we did our due diligence, there's nothing here. And the patient should be referred for genetic counseling for herself and some family history. And then I did this long comment describing everything that I have just told you so far. And after that, we presented this case at the MCC. The patient has been sent to genetic counseling. Her family is also being looked at, and she has, I think, 3 sisters, so they're all being evaluated now. But that's the gravity of this diagnosis rather than the pathologic findings themselves. And so that's why I wanted to present them. And thank you for your time.
Well, thank you so much for this very interesting case. We've already got a question for you from Dr. Hassan. How would you differentiate between JP and complex sclerosing lesion in a core biopsy?
It's hard. So see, in this case, it was diagnosed as FCC as well. And you can't, unless you have other clinical, so if you look at the imaging, it's a large mass, it's cystic, solid, if they say something like that. But really you can't. So for this, we need to look at the entire lesion.
Thank you. On imaging, did the radiologist present with that differential? Because it's usually very typical.
Yeah, no, they didn't. And, as soon as the PAs called me into the gross room, they were like, Sonal, do you want to look at this case? We don't know what it is. How many sections should we put in? And I'm like, this is Swiss cheese disease of the breast. And so they should have, but they didn't.
Right, yeah. Very interesting case, thank you.
Sure.
Any other questions? No, well, thank you so much. If now we'll move on to the next presentation from Dr. Miriam Murkonich from Mount Sinai Hospital. So Miriam, if you'd like to start.
Sure, let me just share my screen. Okay, can you see the screen?
Yeah.
So it's a case of a 43-year-old woman who had a previous history of left benign Phyllodes tumor, and now she presented with bilateral breast masses that they were both homogeneous and oval on imaging, and they have been rapidly growing. So in the right breast, she's had a number of masses, the largest one being just over 10 centimeters, and then additional ones that were over 4 centimeters, 3 centimeters, and 2 centimeters. And then the left breast, where she's had her benign Phyllodes tumor, the largest one being almost 7 centimeters, and the next one almost 3 and 2 centimeters. So the largest masses have increased rapidly in size compared to prior imaging, and they have both undergone needle core biopsies, which were signed out as cellular fibroepithelial lesions, further classifications or diagnosis done on excision specimens. So they've excised the 2 largest masses from the left and right breast, and they both had pretty much identical histomorphology. So on the lower power, there was somewhat fairly well circumscribed masses. You can quite see some benign glandular breast components, and then there's the expansion of it going down into and infiltrating into the surrounding adipose tissue. When you start looking at these at higher power, again, you notice that there is this expansion of what looks more like a stroma or a fibrous component. And then the epithelial component seems to be comprised primarily of these benign ducts that just seem to be kind of along for the ride, if you will. And the lesion is present all the way to the inked margins. So if we keep looking around the lesion, you kind of keep finding more of the same. There's a bit of heterogeneity in terms of cellularity. There's some paucicellular areas, along with some more, at least moderately cellular components. And in terms of the stromal cellularity, again, it's kind of mild to maybe focally moderate if you see some nucleoli, and mitotic activity was fairly rare. It's under 5 per 10 high power fields. And you start to notice that maybe there's some of this growth kind of circle, at least goes kind of circumferentially around some of these benign ducts. And again, just a high power view just to demonstrate kind of these lesional cells and some of these ducts, which predominantly just had maybe some columnar cell change with some focal hyperplasia. And then there were areas where you just pretty much saw stroma, so kind of akin to stromal overgrowth. The lesion was CD34 positive, ER/PR SMA desmo negative. And in the context of her multiple lesions and a history of benign Phyllodes tumor, this was diagnosed as periductal stromal tumor. So it's a biphasic tumor of benign ducts that are set in cellular spindled stroma, and they occur in both peri and postmenopausal women. Unlike Phyllodes tumors, they lack true leaf-like architecture. There's a varying degree of atypia and mitoses. They do tend to be fairly infiltrative, and they are regarded and classified in WHO as a subtype of Phyllodes tumor. And because of that, they also tend to exhibit intermediate behavior. The literature does describe cases where these have recurred as more of, classic Phyllodes tumors. And the treatment is identical. It's just a wide excision, making sure that all the margins are negative. So you may also in the literature find terminology, I think predominantly from the Armed Forces Institute of Pathology, where they were referred to in the past as periductal stromal sarcoma or periductal stromal hyperplasia, which were both rather confusing terms, but now they've just been classified under Phyllodes tumors. So that's pretty much it. Just a short and quick case.
Thank you, Marilyn. That's nice and sweet.
Let me stop the share.
All right. So we've already got a question from Dr. Bushkin. This is regarding if the stroma changes resemble PASH.
Yeah, they do. A lot of the areas do resemble PASH, but unlike PASH, as I mentioned, these tend to be ER/PR negative. PASH tends to be both ER/PR positive, PR more than ER, and also Dasman. That's why I included those immunos in the presentation, because there are areas that are very much PASH-like and some that are not. But that's a good observation.
Marilyn, that's a great case. So I haven't used that term. I guess it reflects how I was trained, and everything was put in the Phyllodes category.
Right.
So I was wondering, did you have a chance, are we able to compare it to the original Phyllodes that was diagnosed, and was the morphology similar, or was it more classic in the original Phyllodes?
Unfortunately not, because it was done at a different institution.
Right.
But we're able to look at natal core biopsies and they look the same. So, but no, that would have been a good thing to see what the original looked like and how it compared.
And in terms of the imaging, were the lesions very well circumscribed, or were they less well?
They were described as
Okay.
well circumscribed. Yeah.
Okay. Yeah, it's interesting. So because I don't use that term, I think I'd probably have difficulty even assigning them into which category. So I presume most of them fall into the benign, what would be considered a benign process. And then based on various criteria, you could push it a bit higher.
Yeah. Yeah, it was the first time I've actually used the term as well. You don't see them quite often.
Miriam, I have a question. These were substantially large and multifocal. Was it discussed at tumor board, and whether there was anything mentioned about radiation therapy?
I don't recall, to be honest with you, whether I didn't see her discussed at the tumor boards. We've had a number of cases, younger patients that have had, numerous phyllodes tumors, and it was mostly just discussion about excision rather than a radiation, but I haven't seen her name come up.
Okay.
And there's another question in the chat from Dr. Hajir. Why didn't you consider it as recurrent phyllodes?
So the lesions were both fairly, even though they were sizable, they were fairly well sampled, and I couldn't find your typical leaf-like architecture to put them into phyllodes categories. It was just mostly these ducts that were just kind of spread around and not even forming like TDLUs, just kind of, as I've showed in the image, spread around. So looking at it where it would best fit overall, it ended up being in this category. Not really sure, because there are also, she had left phyllodes, but these were bilateral lesions. So, and they were both identical. So the one on the right would not have been a recurrence phyllodes. So I figured this would kind of fit the criteria for both. If that makes sense.
I struggle with these funny lesions that don't have, that typical leafy growth, and don't look, so much like a fibroadenoma. When you get that stroma, especially, that looks like that, and fat, and I've had many cases where I actually, wasn't sure if I should be calling it a hamartoma, or all the way up to, phyllodes, even a borderline. I think they're quite challenging. I think, those that don't follow that sort of very textbook pattern of growth for phyllodes, those biphasic lesions that, I think, and again, it's another area that's quite challenging for us to accurately classify. And I presume they both looked identical.
They did look
identical bilaterally. Okay.
Yeah. And I think that the presentation has images from both, because they were both the same. And it did help to know her prior history.
There's another question. So this is from Dr. Talati. Was CD34 diffusely positive?
I didn't include it here. I don't recall whether it was diffusely positive, but it was definitely positive.
So any other questions from anyone? No, well, thank you, Marilyn. All right, and we'll move on to the next presentation, which is actually coming from me. My name is Jessie Wu. I'm from St. Michael's Hospital. So I'm presenting a diagnostic conundrum. I have a 54-year-old woman who presented with 2-month history of a palpable left medial chest wall lump. Her past medical history is significant for left breast atypia 5 years ago. I didn't manage to find the actual pathology report for this. This was just only mentioned in passing in the clinical notes, and this was decided to be managed non-operatively. On clinical examination, it was a palpable mobile nodule located in the left medial breast, adjacent to the lateral border of the sternum, and is roughly 2 centimeters in length. In terms of the radiologic findings, on mammogram, it's well circumscribed, shows equal density, oval mass measuring up to 25 millimeters. On the ultrasound, again, it's an oval circumscribed mixed echogenicity, solid mass measuring up to 19 millimeters. According to the imaging appearances, the radiologist actually thought it was most likely to correspond to some kind of benign appearing fibroepithelial lesion, like a fibroadenoma. Okay, so here we have the core biopsy on low power, and on slightly higher magnification, you can see that there are some rather bizarre looking cells. Okay. Now, I do have the excision specimen as well, so I won't dwell too much on the biopsy specimen here. But here you can see that there's a mixture of fairly pleomorphic looking multinucleated floret-like giant cells, and then you have like these spindle cells as well. You have maybe some ropey collagens here. In terms of the immunohistochemistry, it's diffusely positive for ER and PR. Patchy reactivity with CD34, Desmin, and SMA, and there's absence of staining for PEN-CK, GATA3, 4B5, MDM2, or CDK4. So this was, in terms of the final diagnosis, this is put down as a spindle and giant cell lesion, with a comment saying that the differential diagnosis includes a spindle/pleomorphic lipoma and a mammary type myofibroblastoma with giant cells. And this is best classified at excision. Okay. So here is the excision specimen. So on low power, you can see that it looks fairly well circumscribed as noted on the radiology report. Okay. And if we go a little bit higher, you can see that this is a fairly cellular area. Again, you notice all these kind of big blue cells. And you can see that they have kind of pretty big nuclei with irregular nuclear contour. And they're pretty hyperchromatic as well compared to the background. Okay. On this view here, you can see some wreath-like giant cells, kind of reminiscent of floret cells we see in pleomorphic lipoma. You also have kind of thick-looking collagen bundles here. Okay. Mitoses were actually fairly easy to spot in this case. Okay, and here's another one. And you can see that some areas are a little bit more sparse. Okay, so within the same lesion, you can have certainly less cellular areas. And here you can see some scattered adipocytes as well. Okay. And you notice that in the background, it has a more myxoid look. And again, you have the collagen bundles. Okay. Again, within the same lesion, there are areas that's occupied by more spindle-looking cells with kind of pretty mild to moderate nuclear atypia. Okay. So this is the list of differential diagnosis. Of course, we still have to consider invasive breast carcinoma. And there are some features, as mentioned before, that kind of reminds me of pleomorphic lipoma. So that's one of the considerations. And along those lines, there's atypical pleomorphic lipomatous tumor, atypical lipomatous tumor / well-differentiated liposarcoma, pleomorphic liposarcoma, and finally mammary type myofibroblastoma. Okay. The immuno shows no staining for PEN-CK, GATA3, S100, or MDM2. Here with SMA, you're starting to see some focal staining. Okay. The ER staining is a little bit more diffuse, although it's kind of on the weaker side. Oh, sorry. Here, this is the ER, kind of diffuse weak staining. And the Desmond and CD34 all have focal staining. Okay. So to summarize, we have a well-circumscribed nodule with kind of cellular spindle cells with mild to moderate atypia. We have abundant floret-like pleomorphic multinucleated cells. We've seen some atypical mitoses, kind of small adipocytic component, a collagenous background with some myxoid change. And here's a summary of the histochemistry. So taking the kind of morphology and the immunohistochemical profile, and most importantly, in consultation with the soft tissue team, this was, we ended up calling this atypical pleomorphic lipomatous tumor. So this is actually a new tumor entity incorporated into the 5th edition of the WHO Blue Book. So the full name is actually atypical spindle cell / pleomorphic lipomatous tumor. It's considered a benign adipocytic neoplasm. It arises usually in the subcutaneous, slightly more frequently than the soft tissue. It predominantly occurs in the limbs and the limb girdles, and less commonly it can happen in the head and neck area, genital area, the trunk, and the back. It's seen predominantly in middle-aged adults with peak incidence in the 6th decade. There's a slight male predominance. Okay. In terms of the pathogenesis, there's deletion or losses of 13q14, including RB1 and its flanking genes. Clinically, the patients tend to present with persistent enlarging soft tissue mass, nodule, or swelling, and sometimes there can be tenderness associated with it. Microscopically, it's usually unencapsulated with a nodular, multinodular growth pattern, and it can vary in size quite considerably. In terms of the microscopic appearance, it's got quite a wide spectrum because it can have essentially variable proportions of the atypical spindle cells, adipocytes, lipoblasts, pleomorphic cells. And then again, you have that kind of myxoid to collagenous extracellular matrix background. Mitoses tend to be rare and tumor necrosis is absent. Okay, so the morphology of these, what we call APLT, can be quite a broad spectrum, as mentioned before. So at one extreme, you can have like really paucicellular, cytologically blend spindle cells. with predominantly kind of extracellular matrix. At the other extreme, which is, I think, what we have in our case here, we have something that's really highly cellular with lots of spindle cells, lots of these giant cells. They almost look like, like fibrosarcoma. In terms of the ancillary test, it shows variable CD34 and S100 protein expression. Desmin can be focally positive. You have loss of nuclear RB expression in about 50% of the cases. MDM2 CDK4 are usually negative, and there's no MDM2 amplification. So interestingly, for the prognosis, even if the tumor is incompletely excised, there's a fairly low rate of local recurrence, only between 10 to 15%. There's no documented risk for metastasis, and there's no risk for dedifferentiation. Okay, so in summary, APLT has a wide range of microscopic appearances. There's a long list of differential diagnoses. Morphology is extremely important, but again, most importantly, please consult your soft tissue colleagues. So if anyone's got any questions.
There is a question in the chat, Jessie.
Yeah.
Pleomorphic lipoma is an atypical lipomatous neoplasm. Is atypical pleomorphic lipoma a redundant term? Or is it an atypical form of pleomorphic lipoma?
I think I need to unpack that a little bit. Okay. Sorry, I'm just reading the question from the chat now. Okay. Okay. So I'm gonna let's see. So I think. So this new diagnostic entity actually came out of what was called, sorry, let me double check. So this was proposed because initially they came up with atypical spindle cell lipomatous tumor. But I think in terms of distinguishing between pleomorphic lipoma versus atypical pleomorphic lipoma is the fact that we because of this other kind of morphologic extreme where you can have things looking really atypical, as you can see from the images that I presented. When I first saw it, I thought they looked quite scary. You have these ginormous, very ugly looking cells with an atypical looking mitoses. So I don't know. And then there's also obviously the association with the loss of RB. So I think that's one of the distinguishing features, although we only see that in about 50% of the cases. So.
And Miriam has a question that I was wondering about as well. Did you do molecular testing, and how do you differentiate them from myofibroblastoma, which also lose RB1 and can be lipomatous?
Oh, gee. So I didn't actually do molecular testing in this case. This was actually passed on to the soft tissue team at Sinai. And this was kind of diagnosed based on the morphology and the immuno findings, basically. I think you raised a good question in terms of how to differentiate this between with myofibroblastoma. I guess in terms of the, it's a combination of, I guess, patient characteristics. In, I guess, myofibroblastoma, you do have more of a male predominance, and also the immunohistochemical profile. It's tough. I mean, this is something that that you really need to do in consultation with the soft tissue team, I think. Yeah.
Yeah, I think it's one of those where you probably don't want to sign it out without their help. But you know, we do at least the books talk about the atypical myofibroblastomas. So it's likely that we're talking about the same lesion, that we just call them different names depending on, you know, who sees it. One of those issues again. Can you comment, Jessie, on the ER staining? I mean, outside of the breast, what does ER do in these? Or
So I don't actually have any literature references, but speaking with Dr. D'Amico, she actually tells me that quite often you do get ER/PR positivity in women and AR positivity in men. So I don't have any literature per se to back that up, but from her experience, that seems to be the case.
all these tough questions is just a sign of how interesting the case is. So there is another question. You exclude metaplastic carcinoma by doing PAN-CK and GATA3, and don't we need to do further SOX10 and P63?
Yes, that's probably advisable, but I didn't show the whole panel, but we did do quite extensive immunostaining for this case, yeah.
Wouldn't positive ER favor a myofibroblastoma over APLT?
So as mentioned previously, according to the soft tissue pathologist, that ER tends to be positive in females with APLT apparently. So
Great case.
Yeah, thank you very much, Jessie. I hope not to see it anytime soon in my practice.
I feel the same.
Yeah.
I think it's important though, the ER positivity, because it's the same in a myofibroblastoma. If you don't do a cytokeratin, and in some areas it looked almost epithelioid in some of the images you showed. So if you weren't to do a cytokeratin and just did the biomarkers and got this ER positivity, you could easily call this an invasive carcinoma. You know, with that staining pattern. We see that more in the epithelioid myofibroblastoma type, but yeah, when it looks that odd, I guess it's a good idea to do quite a broad panel of immuno, just to make sure that you aren't misinterpreting the unusual morphologic features.
Absolutely, thank you. So next up, we have Dr. Amir Samani from Humber River Hospital. Would you like to share your slides?
Hi, yes, let me go to the presentation mode. And I'm presenting a survey I did on the size measurement in mucinous carcinoma of breast. My story started from a case I had at Humber River Hospital, and I reported as a mucinous carcinoma, and the size in measurement was, I don't know why it's, let me close this one. Okay, it was around 2.8 millimeters, and I staged it accordingly. This case was reviewed by a breast pathologist, and my staging downgraded from PT1A to T1 microinvasive, because only the area with the cellularity was counted. So it actually raised the question in my mind that to measure the size of mucinous carcinoma, should we measure the whole surface, including acellular mucin, or only the area with floating cancer cells? And I emailed this question to few pathologists, breast pathologists in Canada and US. So I got answers back. So 64% said any mucin, cellular or acellular, is counted. 18% said only area with floating mucin cells are counted, and 18% answered me with an if. And I'll go through the if in a moment. So the people who called said they count all the mucin. They said many invasive mucinous carcinoma are paucicellular, especially type A. And if we did multiple levels on areas of mucin, we would probably identify clusters of carcinoma within it. So they use this reasoning to use cellular and acellular mucin for staging. One of the pathologists wrote me, in courses where we provided the slide sets for over 100 participants on several occasions, we found cells only as deep as a slide 40 to 44 or 83 to 86. And people who responded me that they count only floating cancer cells, they said, I would get levels to see if it gets bigger, and I would measure only tumor cells, not free mucin. Some people put an if in their answer and said, I will measure the area with floating cells. And they asked me to take more levels and email them. And some of them said, now I believe that the mucinous stroma is part of invasive component, although there is no cellularity. And therefore, I would include the measurement of acellular. And some said, if the mucin is in continuity with the area with the cellularities area, acellular with cellularity, then I would include it in the measurement. It means that to some pathologists, the whole area of mucin cellular with cells, cellular, and without cell, acellular, are counted as a staging and the measurement size of the mucinous carcinoma. In some pathologies, only the area with cellularity and area that has no cellularity, if it's in continuation with the cellular area, is counted. If like this area is not in continuation, they call it mucocil-like lesion, but not part of the mucinous carcinoma. This is, for example, one of the mastectomy from a case of mucinous carcinoma, which had positive margin. And the pathologist actually reported this one as negative for any residual carcinoma because there was no cellularity in this mucinous pool. This is the from our hospital, negative for residual malignancy. So what are the importance of this acellular versus cellular mucin? It's important in tumor staging, as I said, size of the tumor and management consequent to that. In terms of grading, if you have multiple microinvasive mucinous carcinoma and you don't count the whole as a continuous, you have multiple microinvasive foci and you don't need to grade them microinvasive foci. It affects the status of the margin assessment, lymph node staging and extranodal extension, and also affects the post-node adjuvant therapy treatment response in the acellular mucin. This is, for example, one of the cases that, as you can see, there is some free mucin close to the margin or at the margin. And but these are just macrophages, but no cancer cell. So depends on the school of thought, we may call it differently. This is another case that the cellular area has actually some distance from the ink, and the acellular part is at the ink, like here, for example. So it makes some differences. The same as here, for example, the acellular mucin is at ink, the cellular mucin is not at ink margin. This is the implication in a lymph node. In this lymph node, there is no cellularity. As you can see, it's only free mucin. So, but the size of that is more than 2 millimeters. So if he believes in cellular or acellular, it makes some difference. And this is high power of that, just few lymphocytes. This is another case, 12 millimeters acellular mucin, and only at the edge, I have few floating cells. Again, if you go with just cellularity area, these are isolated tumor cells or microinvasive. And if you go with the cellular, it actually is a macrometastatic. And another case, the same area you can see, you have subcapsular invasive cells here, and the rest is totally acellular mucin. and the size of each is good for isolated, and some of them are good for macro. And another problem, as I said, is evaluating the post-neoadjuvant treatment response of the tumor. So this is one of our cases. Patient had triple negative mucinous carcinoma, got neoadjuvant therapy and then surgery done. And as you can see, there is a lot of free mucin foci here, and only few cells left here. So it's kind of a dilemma how to report it. Is it good response? Is it not? Is it not responding? This is higher power. You can see that it's mainly free mucin with few floating cells. So another area you have more floating cells, but again, a lot of free mucin. This is the core biopsy of that case, which actually got back triple negative. And you can see that the cellularity was high. So probably this patient had some response, but we don't know because it was just a core biopsy. This is higher power of the core before neoadjuvant. This paper actually looked at this problem, invasive mucinous carcinoma of breast and response pattern after neoadjuvant chemotherapy from Albert Einstein College of Medicine. They looked in their file between 2011 and 16. They found 7 patients treated, had mucinous carcinoma treated with neoadjuvant. And they said clinical and imaging assessment of response showed persistent and in some cases progressive disease despite evidence of significant pathological response. Pathological assessment after neoadjuvant treatment demonstrated marked reduction in tumor cellularity, but persistent space occupying mucin pools. And what they conclude is important. Persistent mass forming low cellular or acellular mucin pool can result in discordant clinical imaging and pathological findings. So the conclusion is size determination in mucinous carcinoma is a matter of controversial issue. We may need to cut many levels to find more floating cells, especially for grading and mitotic count. And if we believe in excluding acellular mucin, we need to cut many levels to be sure that the margin status is basically acellular, not cellular. The last word is about the silicon as a pitfall for diagnosis. As you know, silicon is used in capsule, used for the implant, and it may resemble the mucinous carcinoma. So it's important things to be aware of that. And these are the look of the silicon released from the capsule. And importantly, some people may use augmentation, breast augmentation, using the raw silicone injection into the breast, not the capsule. So that actually may make the same picture as mucinous carcinoma. As you can see, they really look like mucin, free mucin. And interestingly, they are mucin positive. With mucicarmin, they are positive. With Alcian blue, they are positive, but they are negative with PAS and PASD. Thank you.
Thank you so much, Smani, for Dr. Smani, for this presentation. You raised a very important and practical question that I'm sure we all encounter in our clinical practice. So what do you do now?
I basically put a note in my comment that I use this criteria to include the acellular and cellular mucin for staging and for margin status. But, you know, it's up to them because sometimes the surgeons don't like to go and repeat the lumpectomy or re-excision or mastectomy because they don't really think that anything is left, and they don't believe that free mucin is important. So it's up to them to decide. I put a comment. And for the lymph node, the same. usually it's not only one lymph node found, which is showing free mucin. Luckily, we have other lymph nodes with some cellularity. But again, if I have cases like that and I'm on the on a situation I should choose between these things, I put a comment.
So do you ever get comments from the clinician being like really confused when you put this comment in, and then they kind of have to make the decision themselves?
In the tumor boards we've had so far, no comment.
Right.
Mucinous carcinoma are not like frequently happening, so we don't have that many cases. But as I showed, we had post-neoadjuvant case. We had cases with lymph node only with free mucin. It may happen. Yeah.
Thank you, Dr. Samani. So my understanding is the convention is that you do use the mucin, you do include the mucinous component to measure inframargin status, at least in the untreated cases. Although I do think the case you showed is a particularly challenging one, given that it's such a small focus, and you could try and separate the areas because it's at that microinvasive versus larger. So I think you probably would get and you did get a range of answers for that one. In terms of the lymph nodes you showed, were they in patients post-neoadjuvant or untreated patients?
Sorry?
In the cases with the lymph nodes, were they in the neoadjuvant setting?
No, it was untreated patients.
Right.
Yeah.
So I'm particularly because mucinous we always think as this lowish grade tumor with hormone receptor positivity, and lymph node mets are uncommon. At least that's what the literature says. So that you're able to collect some cases like that is particularly interesting. And the triple negative status of that tumor would make me think that if you saw more of it, it's unlikely that it was a pure mucinous. It was probably more an NST with mucinous features, given the triple negative status, although it looked pretty good for mucinous, pure based on that one. So it is a very interesting topic, and it really sort of emphasizes how we struggle to just even size, invasive cancers, how the range of, sizes you get if you were to send out, okay, that's better. If you were to send out a bunch of cases to be staged, I mean, I think it's one of those things in applying something that is a measurement that we all struggle with. Yeah, but very interesting case. Thank you.
Thank you.
So maybe I'll ask from our moderators to just give their opinion. How would they stage and how would they consider that lymph node? I find it's extremely challenging, especially in the pre-treatment setting.
For me, after neoadjuvant, I would probably will not count acellular mucin as a residual tumor, because I think that the mucin itself, while being delivered or is a product of the cancer, it cannot be absorbed using systemic therapy. In chemo-naive, I think that I would include it as a positive node. And I think that this is so rare that it will need to be discussed as case-by-case discussion. I don't think that any of the randomized trials used to inform us about the clinical significance of histopathological findings really had enough cases of this sort to allow for appreciation of the significance of them. So the most important thing will be just to convey what you see.
I have to agree with Sharon. Acellular post-treatment PCR, unless you can confirm that there's epithelium, lymph nodes and breast. In the untreated, you know what, I don't think I've seen this before. And, when you think about it, even in the non-mucinous setting, you're looking at volume of disease in a lymph node. When we measure, we're trying to find the best approximation for the volume of disease in the lymph node. That's why we measure just contiguous epithelium rather than including intervening lymphocytes. Otherwise, we're going to overestimate the volume of disease in the lymph node. So it doesn't make a lot of sense, I would say, then in that setting to measure across the mucin. But as Sharon says, we don't have data in this particular, because it's so rare, we don't have data to say how, you know, what it means in terms of long-term outcome. So I think I'd probably be descriptive as well. And yeah, I would struggle to measure all the way across acellular mucin in an untreated, in a lymph node setting in an untreated patient.
Okay, I think that we have our last presentation coming, right, from Polycarp.
Yes, that's correct. So we have Dr. Polycarp Erval from Trillium Health Partners, who's going to present his case.
Thank you very much, Jessie. I'll just try to share my screen. Luckily, it's a straightforward case. I just think it's interesting to remind us that this kind of cases still exist. So she's a 70-year-old female with a new nodule in the left, lower outer quadrant of the right breast. So clinically, they couldn't decide whether it was cystic or solid. It looked funny to them. And so the ultrasound showed a hypoechoic nodule, 5 millimeter in size, same position, lower outer quadrant, 11 cm from the nipple. It had abnormal flow with Doppler evaluation. What that means, I don't, with Doppler evaluation, there was no abnormal flow. So the impression was a small complex cyst, and they recommended 5-needle aspiration. FNA said atypical cells, and that prompted a core biopsy. The core biopsy is unusual, and that's the emphasis I'm going to make here, just an unusual. So you see this is a low power view of a core. Now it's easy to understand why they thought it was cystic. You can see a well circumscribed lesion. Really there's nothing you can say about it, just this lesion that some people would think is papillary at this power. Others will just wonder what it is. A solid, we are not sure. So even at an intermediate power, there's nothing to see. So I just jumped straight to a high power to look at the cytomorphology. Architecturally, it was just that solid sheet of cells that is not papillary. So you can see that there are no fibrovascular cores. So we just have these polygonal cells that are lumped together, and the lesion is quite cellular. If you go further, this is about the highest I could get on the slides, that on the magnification I was using. But if you look at the cells, they're just round polygonal cells. Some of them have cleared cytoplasm. Others seem to have some amphiphilic or vaguely eosinophilic cytoplasm. Nothing really to hold on to. In the surrounding tissue, there were normal terminal duct lobular units, but in the lesion itself, this is all that it showed. And you go to the border of the lesion, it wasn't outrightly infiltrating, so it was well circumscribed. And even though you could see some, erosion into the normal breast parenchyma, but it was, generally well circumscribed. Cytology described round cherry red nucleoli. I didn't appreciate it much on the histology, but you could see some occasional prominent nucleoli. Important, there was no elements that I could say was inside to carcinoma. So this is a summary of the histology features. solid tumor composed of tightly packed cells, amphiphilic cytoplasm, no areas of necrosis, no mitosis. There were some scattered inflammatory cells. We did some, so these were the differentials that came to my mind initially. And somebody had actually seen it before referring it to me. And so did some stains along these lines, and I would just say they were all negative. This is P63. It didn't show any myoepithelial cells. And on the edge, you can see the normal, ducts with its, like a good internal control. This ER, completely negative. Pankeratin was positive. So I'm just going to skip. I just scanned. Those are all my slides. I'm just going to show the list of the stains that we did that were negative. Cytokeratin 7 was negative. ER, PR, GCDFP was negative. GATA3 was negative. S100 was negative. Eliminated granular cell tumor. People thought about melanoma was negative. This is obviously not the case. So we did a new panel of stains, and they were all positive. Renal cell carcinoma, PAX8, Vimentin, CA119. So like I said, just to remind us that these cases still exist. It was a metastatic renal cell carcinoma to the breast. Additional digging into the history discovered that this patient had a nephrectomy some years back in another province. So it was not very obvious. I have about 3 minutes. 1 minute actually. I'll just run through some slides that I have. I'll be really brief. So this is a list of the common metastatic lesions to the breast. From the contralateral breast is the most common, and then lymphoma. They are not very common lesions. They constitute only about 0.2 to 1.1% of all breast malignancies. In an autopsy study, they discovered that about 4% of patients with hematological malignancies had a metastasis to the breast, 1.4 for people with extra mammary solid lesions. So you can tell that it's not very common. Mode of spread is usually hematogenous, but if it's from the contralateral breast, you can also have lymphatic spread. I'm just going to skip this. Radiology is usually a cystic lesion or a solid lesion. They can't really distinguish, so it doesn't help. But the most important thing in morphology is the unusual pattern. And so when you see something that doesn't just add up, you can't really place it here or there. And then lack of insight to carcinoma will also reinforce that thought in your head. And then the literature says you have predominant periductal and perilobular distribution. In this case, there was no normal breast duct in the vicinity. And extensive LVI may point to it, but that can also be a red herring because when you have extensive LVI with expanded ducts, you can think it's a DCIS and actually lead you to a wrong path. 30% lack specific features of the primary lesion, but the others, about 70%, will have specific features of the primary lesion, some of which I've listed here. The key will be immunohistochemistry, like we see. Unusual histology. This is a picture from the current WHO manual. You have unusual histology. What do? If it's triple negative, you look for the cytokeratin. Then, if cytokeratin is negative, you have these differentials. So I'm not going to go through this, but IHC can really help. I want to just show one more slide at the end, which is this people that studied 74 biopsies from 66 patients that had metastasis to the breast. It constituted about 0.96% of the breast lesions they had in that center. So that's within the range of 0.2 to 1.1% of all breast lesions. What I want to emphasize here is on this is my last slide. So in this series, most metastases were from the lung, and of those in the lung, 90% were adenocarcinoma. And most of 90% of, 12 out of 22 were adenocarcinoma. Now, of the adenocarcinomas, 90% of them were initially reported as primary breast NST. And I mean, that's obvious. If it's lymphoma, you can tell easily. Melanoma is easier to tell, but these ones will look like dogs, and so it can be misleading. And to add to it, most of the time, the history doesn't usually support, they won't give you the history, so you have to have that index of suspicion. So like I said, I'm just presenting this to remind us that this lesion still exists, was a metastatic renal cell carcinoma to the breast. I hope I tried. 3 minutes over.
Thank you, Polycarp. Any questions?
There's time for comment. I can emphasize how important this issue is, and we deal with it on a daily basis. When we don't see in situ in our cores, and they have to be signed out, so we can't even wait for biomarkers to give us that extra bit of support. So, you know, when do we decide to add in an extra couple of immunos just to kind of, you know, do a little screen to make sure I'm not missing, you know, a MET. And we do spend a lot of time looking at histories to see if there is anything. But as you say, 20 to 30% don't have. This is the first presentation. So, you know, it's a real issue. And I did recently enough call something invasive ductal carcinoma, which turned out to be a metastasis from a lung. So it's quite fresh in my mind. And it wasn't until I got the triple negative biomarkers that I realized it wasn't concordant, and nothing, they couldn't find anything in the lung, but with the workup it all fit with the lung primary. So it does happen. But thank you very much for that.
We do have a few questions in the chat room. So very quickly, Dr. Ghada Nassar just made a comment about in triple negative tumors, we should raise the possibility of metastasis. So GATA3 and SOX10 is crucial. The next one is, do you discourage use of cytology workup of breast lesions other than therapeutic drainage of cysts and lymph node aspirates?
Well, yeah, well, I think the current practice discourages it generally because we don't have enough tissue to work with. I know when I was in med school, FNA used to be the first step for breast lesions. Now it has changed. Core biopsy is the first step. So we do discourage it. Even here we have a surgeon who always does FNA for breast lesions, and it's quite frustrating because most times we can't tell anything. They have to go back. So, but in this case, maybe it helped because it helped from the. Well, I don't think it's actually superior in any way because core biopsy will give you more tissue. So I don't know what other people think, but I think it's generally discouraged now.
Okay. Well, thank you so much. We're going to wrap up the meeting now. Thank you, everyone, for attending. And thank you so much, Dr. Mulligan, for your amazing presentation. We really appreciate it. And thank you to all the presenters. And I would like to encourage everyone to kind of bring around cases that we commonly encounter to these meetings. So if you have anything you'd like to present, please let me know. So thank you.
And also quick reminder, please fill out the survey that you're getting. And those of you who need CME credit especially is encouraged to fill out the survey. We do read the survey and we try to please you all in the next events. Thank you, everybody, and goodbye for now.
Okay.
Thank you. Bye-bye.